And it was Straightsmile Solutions, straightsmilesolutions.com. And today we're going to talk about a few journal articles that they're kind of tricky ones to read, but I've kind of digested them a little bit. I've listed the citations here. There's 3 of them. And this is nothing that I probably haven't already told you in my other videos, but which movements, especially in adults, we're talking about adults, are very predictable, kind of predictable, and not that predictable. And these are things that definitely orthodontists are aware of. So for high predictability, the research shows, no surprise, expansion, very easy. That's tipping teeth wider, making the arch wider. We're not talking about skeletal expansion. We're talking about arch expansion, dental expansion, basically tipping. In kids, if you want skeletal expansion with airway benefits, you do need to use a palatal expander that breaks the suture and opens up the jaw. Always way better. And you can get these from any orthodontic appliance company that's out there, really cheap, really low cost, and pretty soon Invisalign is going to be launching their own brand of expanders that works synchronously with their clear aligners. It is just launching right now. I haven't used them yet. Another one is distalization. That's one of my favorite movements, and I feel like it's something that, for the most part, general dentists and pediatric dentists are not being taught distalization. It's not something you're going to really do that much in kids unless you're trying to upright a molar because you lost an E or something like that. But you can totally do it in adults, especially when there is a lack of third molars. It is an amazing movement. It allows you to cut out expansion and proclination, especially in a patient that maybe has periodontal disease or just can't expand and procline due to lack of bone. You don't have to cut teeth, you don't have to pull teeth. Very predictable movement, especially when you throw an attachment on there. Highly recommend it, but of course, you got to consult the panoramic x-ray, because if there's no space or you're jamming a tooth into the ramus or into a maxillary tuberosity, that's not going to work. So put your dental hat on before you pick a case for that. Here's some other movements that are moderately predictable. They're pretty good, tipping teeth, or proclining or retracting. Rotation of teeth generally works pretty well as long as you put attachments on. If it's a lot of rotation, you want to make sure you create space first, just like you do in braces. So that's why I always strongly recommend that all dentists take a braces course first. I mean, not just like a baby braces anterior movement, like a comprehensive braces course. I don't care if you do it or not, but at least you'll understand how we do things in braces, and then that translates so much easier into understanding how aligners work. Create the space first, make sure there's handles on it, and if it's a round tooth, you're probably going to need 2 sets of attachments, yin yang, one on the buccal, one on the lingual. I even do that on molars, premolars, and sometimes I do it on canines. Sometimes I do it on front teeth. But it generally does work, but you have to keep moment and counter momenting your attachments. You got to keep shifting them as it moves. So it involves coming in, removing attachments, redoing attachments, but it does work. I've spun teeth around like almost 360 degrees before. It definitely works. Another one is mesial distal tip, uprighting the roots. Torque, which is the buccal lingual torque of the roots. And the low predictable ones are, no surprise, in adults, intrusion and extrusion. No surprise. And don't forget, anytime you have an anterior open bite case, please don't do extrusion. You need to really get rid of the habit first, because these cases will relapse even with bonded retention. I see it all the time. There's been a few times when I've had cases where I just didn't notice that there was some type of habit, be it tongue thrust, mouth breathing at night, some of the stuff you can't see clinically, and the patients don't always report it. I've gotten pretty good at looking at mouth and bites now and knowing when there's something going on. But if the patient declines OMT therapy and you decide to proceed anyways, even if they have all these different releases, guess what? You're still probably going to get yourself in trouble for taking that case. It's happened to me before. All it takes is somebody to report it to the dental board or someone to report it to the insurance company. More commonly, you will the very least be giving a full refund, if not worse. So I would be highly cautious with extrusion, anterior extrusion cases. I would not take them unless you are 100% positive there is no habit, and it requires you to actually send them to an OMT, get a functional assessment. No, that's not free unless you have one in your office. Intrusion, a little tricky. Just remember, anytime you have a deep bite case, you have to figure out the difference between absolute intrusion and relative extrusion to fix the bite. You're not going to know about that unless you get a ceph and cephalometric numbers. I have an entire cephalometric playlist that is free on my YouTube channel. You can learn about that. A lot easier in kids. A lot easier in kids. So that's why phase 1 treatment. So just to inspire you a little bit, orthodontics is not that hard. It's all a matter of treatment timing, case selection, and making sure you do your diagnostics properly, looking for any and all habits, and you cannot rely on the patient to tell you about habits. You have to figure it out yourself. All right. Thanks so much.